Good afternoon, everyone. We're going to go ahead and get started with our webinar today on speech and swallowing. I want to thank Ashleigh so much for presenting for us today. We're really excited to have her back with us, and she did such a good job last time. We'll have her do it again for all of you folks. A couple of housekeeping items before we get going. We are going to hold all questions until the end of the presentation, and there are a couple of different ways that you can ask your questions during the process. One is if you navigate over to your GoToMeeting panel, there should be a drop-down menu that says questions. You can go ahead and type those questions in there. Those will be sent directly to me, and I will ask the questions during the Q&A at the end. If it's something related to your technology or your sound, go ahead and just type those in and I'll answer those directly. The other option for you to ask questions, if you'd like to ask them verbally yourself, you can use the raise your hand function. There should be a little hand icon on your panel as well. You can click that, that'll be sent to me. I can announce you and unmute you from my end, and you can ask your question to Ashleigh right then and there. For the questions that were submitted beforehand, we'll get to those during the presentation as well. So, also, there will be a follow-up email sent out tomorrow around this time, and that will include a recording of this session as well as any of the handouts that we have, and you can pass that around and you can watch it whenever you like. A couple of upcoming programs that we have at the Parkinson Association of the Rockies. There's quite a list, so I'll run through them pretty quickly. We have a couple of webinars coming up in the next few weeks. The first one is on Thursday, July 23rd on music therapy in Parkinson's. The next will be Wednesday, July 29th on upgrading your DBS system. After that, it's Saturday, August 8th on alleviating on and off periods during Parkinson's. All of those are webinars that are going to be a little bit smaller, and the links to those can be found at www.parkinsonrockies.org/online-programs, or you can just navigate to our main page, the parkinsonrockies.org, and they should be there. The last one that I'd like to kind of emphasize is we have moved our annual E3 conference to a totally virtual format, so everybody is able to attend. This is a free conference for everyone. It's going to be a huge day-long thing with breakout rooms, something that we haven't really been able to do in the past because of the facility that we've been hosted in. But now we're going to be having a whole bunch of breakout rooms, things like that. There is in your panel again a handout with the E3 flyer, and that has all the information on there about how to register, what kind of topics we'll be discussing, all of that good information. So please, please, please check that out. Everybody's welcome. Invite whomever you'd like. It's going to be a big, hopefully successful event, and we're very excited. Ashleigh's been helping out with that as well, with getting some people on board. So without going too long, I'll go ahead and transfer over power to Ashleigh, and we can get going with the presentation.
All right. Make sure you can see my screen there.
Yep, you're good.
So, perfect. So good afternoon, everyone. Thank you so much for taking time out of what may or may not be a busy schedule at this point to spend some time talking about speech and swallowing with Parkinson's disease. I just wanted to quickly introduce myself. I'm Ashleigh Lambert. I'm a speech language pathologist in the Denver area. I am the Vice President of Clinical Development for SpeechVive, which is a wearable device for communication with Parkinson's disease, and we'll talk about that a little bit later. And then I'm also Vice President of the Young Professionals Board for the Parkinson's Association of the Rockies. So first, I wanted to get out of the way, why should I see a speech language pathologist? I know everybody probably has a different level of familiarity with what a speech therapist or a speech language pathologist does. So really what we do is we work on everything from the brain through the diaphragm. So we're working on cognition, thinking, memory, word finding, eating and swallowing, and then also speaking and diction. So all of those aspects are what you would be referred to as speech pathologists for. And then specifically in Parkinson's disease, what are we looking at and what are we up against? We're really looking at that motor planning. How does the word get from your brain out of your mouth clearly? There's a lot of steps that are involved there. Also the sensory side. Are you perceiving changes to your voice or your swallow accurately to what's actually happening? And then the muscle side, just like you know and have experience with the muscle movements getting smaller and then in turn causing some weakness over time, we see and address the same things in the muscles involved with breathing, swallowing, eating, and speaking. And then again, as I mentioned, the cognitive side, we see a lot of changes and it really varies person to person. It could be difficulty multitasking or remembering or finding the words to say or problem solving or holding on to information to execute a task later on. We work on all of that as well. So why are we talking about speech as it relates to Parkinson's disease? It's estimated about 90% of people with Parkinson's disease will experience changes to their communication, specifically their speech and voice. That subset is called hypokinetic dysarthria. Unfortunately, less than 5% of people with Parkinson's are referred to a speech-language pathologist. And when they are referred, we're typically seeing those referrals later in the disease process when we're really paddling upstream. So one thing I want you to take from this is really thinking about, in my toolkit, knowing when it's time to ask for that referral to a speech pathologist. A lot of the larger clinics, like at University of Florida, and I believe Mayo and Cleveland Clinic are doing it now, at diagnosis, you're actually getting referred to a speech-language pathologist to go ahead and do some initial testing so that we know where you're starting. And we can address things before they get to be a big problem and then monitor you over time. The other reason we're talking about speech, and Elena and I were actually talking about this before we started the conference, is really it impacts quality of life and your self-efficacy. As far as quality of life, we're all experiencing some social isolation right now and changing how we communicate with the world. But if you've had a communication disorder or some changes to your speech and your voice, you've probably already isolated a little bit in the past. It may mean that you haven't been taking phone calls and your partner's doing that, or ordering in a restaurant, someone's doing that on your behalf at this point, and you're really not contributing in the conversation like you used to. I had one family that said their dad lost his sense of humor. And it wasn't that he wasn't funny anymore and lost part of his personality. It was that for him to joke and interject in the conversation just became so difficult that he stopped doing that. So really, that speaks to that quality of life piece that is so important and gives us our individuality. On the self-efficacy side, you know what you're going through better than anybody else. You also are the primary team member on your medical and healthcare team. So it's up to you to be able to advocate on your behalf and let people know what's realistic or isn't realistic and what's a priority to you and what isn't. And so being an effective communicator is key in those types of situations that may have more stress and emotion attached to them, which can make it more difficult to communicate. So those are all the types of things that your speech language pathologist would be looking at with you and having discussions with you about. So let's do a real quick Anatomy 101 on voice. So this is a profile cut down a human. And what I want you to look at really is we're going to start at the bottom down there with the diaphragm. That's a big band of muscles that pulls down to help your lungs expand. At the same time, you've got the rib cage that's expanding. When you do that, it allows your lungs to fill up with the air. And you've got that nice lungs full of air. You've got a nice high pressure system that then goes through the larynx, which is your voice box in your throat. You have some valves in there, and we'll see those on the next page. When you get that nice high pressure below, low pressure above, they slam shut, which is wonderful because then when you push the air through, they vibrate. That causes sound. Then we also use that vocal tract to shape the sound. So that's the tongue, the back of the throat, the jaw, the teeth, and the nasal cavity, all working together. So we've got the respiration piece, which is our breath. We've got the phonation, which is our vibration for sound, and the resonance, which is shaping the sound. All of those have to work together and be coordinated. So when we talk about what we're focusing on and thinking about with Parkinson's, we're thinking about that motor coordination. We're thinking about the automaticity, the musculature. Is it, how rigid is your rib cage? Are you able to expand your lungs? And then we're looking at the timing of those articulators, those sound shapers in the resonance side. How quickly are they moving? How crisply? And it's not a strength thing, but it's just, it's, you know, how nicely are they moving to shape those sounds as everything patterns and coordinates together. So as promised, here's those nice vowels, the vocal folds. If I was looking down through the top of your head, this is what it would look like in those circles. So we've got them closed. That's when you're not breathing, and they're open to breathe. When we're talking, they're at a nice closed position, allowing air to go through and vibrate. So we can move our voice box, and that can change the pitch of our sound. Ah, you can actually feel it move. That changes our intonation. We can add inflection by changing both the volume, how much air we allow through, and the pitch. So all of that's working together. So again, I touched on this a little bit earlier. Maybe you can tell I'm passionate about it. Communication's more than just speaking. So we're looking at those cognitive skills and flexibility. When you're talking, you also have to pay attention to your audience, unless you're doing a webinar for the Parkinson's Association where you can't see your audience. But typically you're getting that visual feedback where you can see, are people able to understand what I'm saying? Are they tracking? Are they losing interest? Do I need to pause? What's going on? You're also having to respond to what others say. Think about what you're going to say, process it, motor plan it, and execute that utterance in a timely manner to be part of the conversation. Sensory input. Am I talking loud enough? Am I too quiet? Are my words slurred? What's going on around me, and how can I modulate what my voice sounds like to be better understood? Facial expression. I'm sure maybe now we're all more aware of how much we actually rely on other people's faces when we're listening to them. Now that we're mainly communicating over the phone, we actually take a lot of input out of faces emotionally, and then we all are actually pretty good lip readers. So we're watching all of that together. We know in Parkinson's, we have some of that masking that happens where we have some stiffness and rigidity in the facial musculature that makes it more difficult to read that facial expression and see some of the emotional side of communication. So that can make it harder for you to express what you're feeling and thinking, and then harder for the others to interpret it. Inflection and prosody, I touched on this a little bit as well. This is kind of the musicality and the emphasis that we put on our words in our speech. So that can also change as we have some of that rigidity and changes in breath support. So I wanted to give you an example that probably most of you are familiar with of what voice might sound like with Parkinson's. Remember, 90% of people with Parkinson's are going to experience some pretty identifiable changes to their speech. So I'm going to play this clip of Muhammad Ali, and hopefully you'll be able to hear it okay.
It means people who don't really know much about me, just tell them more about who I am. They'll understand more about the legend Muhammad Ali, carries Slay. And it's a big honor. It makes me feel good that somebody takes time to make a movie about my life. And it makes you humble feeling.
So some things you may have noticed. He had low volume. He had a microphone on there, so it's a little harder to tell, but his volume was pretty soft. He also had that, his speech was fairly slurred. Some people have described it as sounding a little drunk. An abnormal speech rate. He had some short rushes of speech versus a more typical conversational rate. He didn't exhibit any stuttering that I heard too much, but that's also something that some people will report, that they're getting stuck on a sound or a word and having some repetitions in there, or have trouble starting a sound or word. Shortened phrases, that has everything to do with breath support. So when you can't take those nice deep breaths and control how much air is coming out at a time when you talk, you can't speak for as long. You run out of air too soon. So you kind of have short, choppy phrases that can interrupt the understandability of speech as well. And then also, I think Muhammad Ali is a pretty good example of that lack of intonation, real flat sounding, and really that facial masking, making it difficult to read expression. So these are those common changes that we typically see and address in Parkinson's disease. All right, I alluded to this one too. When should I talk to my doctor about my speech? As soon as possible. They haven't been able to find any correlation to stage of disease process and difficulty with speech and communication. It's different. I'm sure you guys are all familiar with the saying, you've seen one person with Parkinson's, you've seen one person with Parkinson's. Everybody's journey is a little different. Linda Ronstadt did an interview a few years ago stating that the first symptom she experienced was changes to her voice. Other people will really report that they haven't noticed any changes into the later stages. So it's very individualized. Really, what matters is, are you experiencing a change that's impacting you? It doesn't matter if someone says, well, I can hear you okay. If it's something that you see as a problem, then that's when you ask for a referral, and that's when it's time to work on it. The other thing, just like with everything else, and I know, cliches, use it or lose it. We know this in Parkinson's, right? You're fighting against it. You've got to keep talking to keep your speech. And again, we talked a little bit about that isolation, and there's an unfortunate kind of downward spiral that can happen where you've been talking, you get frustrated because you're having a difficult time communicating, and so others speak for you, or you pull away from communicating, which means you talk less, which means that it's even more difficult to understand you over time because you're not using your voice, so then you speak even less, which means then we're kind of on this slippery slope where we're going to continue to go down. So you've really got to make yourself use it. And I know that somebody asked a question about that to address at the end as far as how do we keep using our voice. So I will come back to that. So as far as you've identified you've got a problem, you've talked to your doctor about it, they've written an order to go see a speech language pathologist, what can you expect when you go see the speech pathologist? I'm going to show you a video and then we'll kind of go through it.
Hey guys, this is Matt Ramsey with the AMPLIFIER East Voice Studio. I'm getting scoped by Dr. Whitehead of Austin ENT.
All right, so that's one piece of it. So we'll go through everything. That's called endoscopy, and that's something that you'll be referred for as well. And Dr. Whitehead's actually a doctor I've worked with, and he's very good at it. So review the first thing that's going to happen when you go into the speech pathologist. They're going to do a full review of your case history, your medical history, look at the medications you're on, and then really talk about the concerns that you're having with your speech and voice. Really, we want to make sure that we're not just looking at a disease, we want to be looking at you. And this is where that self-efficacy piece comes into play. You have to let us know what your goals are and what the driver is for bringing you in. A big question that I want you to think about and be able to answer is, what's my most important communication or conversation? What's happening there? Who do I communicate with? Who's the most important communication piece for me? That's going to help drive what your goals are. So you're going to spend a lot of time talking about that. You're going to do a cranial nerve and motor speech exam that involves looking really at how the musculature moves. So you're going to be making some big silly grins. You're going to be puckering. You're going to stick out your tongue and move it side to side. And all kinds of things that may feel a little ridiculous, but it really is a window into looking at how the brain's coordinating those movements, looking at to see if there's any weakness or anything we need to primarily address. The instrumental exam, that's what we were just looking at. That may go with a referral to ENT, or the speech pathologist may do it in their office. And that's when we put an endoscope down your nose and can look at those vocal cords. So you could see the vocal cords in the video. That's just like that top-down view of the vocal folds, like I showed you in the diagram. It takes 10 minutes and it's easy to do. And that really is just to rule out if there's anything else going on in your larynx that may be causing a problem. So we want to rule anything else out before we do any type of intervention. They're also going to take recordings of your voice. We'll be measuring your voice frequency, the volume measurements, all of those, and then playing it back so that you can listen to it and we can talk about it together. You'd also be screened for swallowing and cognition. So typically I tell people you get to have a little snack with me and then answer some questions, probably draw a clock. I bet some of you guys have done that before, and you can roll your eyes when they ask you to do it again. And then at the end, there will be a discussion of the results of the examination, talking about all available interventions, and then developing a treatment plan as a team. You'll notice teams in big letters there. It shouldn't be somebody telling you what you need to do. It's a team approach. You talk about all available interventions, all available technologies, and as a team, you decide what's doable. We'll get into a little bit more about the different protocols, and some of them are pretty intense. So you have to be an active participant in order for it to work. So it's important during that evaluation that you ask questions and that you be candid about what's being asked of you. All right, so our primary target when we work on speech with Parkinson's disease is to get loud. And that might seem kind of odd because I've had people come in that have said, you know, I don't feel like I'm quiet. But when we get loud, we actually do a lot of things. So when I say I want you to be loud, it's just like me saying I want your car to go. I know when I want my car to go, I just push on the gas and it goes. There's a lot of other things that happen under the hood. I don't know what they are. I just know when I push down on the gas, it goes. Same thing. When I tell you I want you to be loud, what that's making you do is sit up straight, take a deep breath, close those vocal folds, increase the pressure below, push it out. When we speak loudly, we move those articulators, we enunciate more, and we slow our rate. So I've targeted all those primary symptoms of hypokinetic dysarthria with one cue, loud. That's why that's what we typically focus on. So how are we going to get you loud? There's 3 main ways that we can work on that have been supported by research over time. I'm sure you've heard of some of these. So we've got 2 so there's more than 3. There's 2 behavioral ones, and then there's technology, so 3 types. So behavioral methods are coaching. So that's the traditional kind of speech therapy where you're going to come in and see me. We're going to work through a protocol, and typically it can be anywhere from 12 hours to 16 hours of therapy in a month. Those are hour-long sessions during the week, and then on the days you're not seeing me, and when you are, you're going to go home and do homework. And that homework is going to be to give you that intense practice you need to hopefully take something from being less automatic to more automatic. So we've got LSVT, loud, and speak out in those categories. And then we have technological approaches. We can use personal amplifiers. We can use computers that have pre-recorded phrases and the ability to text to speech. And then we have another device called the SpeechVive, and we'll talk about that as well. So loud, LSVT, loud, and speak out, they're fairly similar. There's a couple differences, but they're falling under that coaching traditional therapy model. So it's going to require you to multitask when you're doing it. You're going to have to think about what you say and how you say it. It requires a high level of motivation. You got to come in and see me whether you like me or not 3 to 4 days a week. You're going to do your homework 7 days a week. And then when we're out of therapy, when you've graduated, you have to continue doing those exercises every day. Remember, you use it or you lose it. So I've got a video, Samantha Landry, who started the Speak Out protocol, has been doing some Facebook Live speech practice groups during quarantine. So I've got one of hers, and this will kind of give you an idea. Real similar exercises are done in both LSVT loud and speak out. So this is kind of what you would be doing on a daily basis inside and outside of therapy.
So, me, over. Hi, Donna and Ella. We're holding it for about 10 seconds. No need to hold it longer than that. Let's go. We are busy filing our taxes before the deadline. Say it again. There are some exercises that talk about naming the steps for different activities, okay? I know that a lot of people like to skip this exercise. They don't like it, or they think it's kind of, I don't know the word, elementary. They think it's too simple. But we've got to make sure we're doing it the right way. The whole purpose of the exercise, of going through the steps of what you do when you're doing a certain activity.
So I think it's probably good. I'm not a professional video editor. It cut a little bit. That's because these Facebook Live groups are about an hour long. That's how much practice they're doing every day. But what you can see is there's a pretty standard protocol. You're going to start with sounds, and then you're going to work up to words, and then you're going to go to phrases, longer sentences, and then put it all together into conversational speech. So that's where you're starting and going, and it's a very stepwise, regimented protocol. So now, switching out of the coaching model into the technology model, we have personal amplifiers. So a personal amplifier is, typically just a little speaker and a headset. There's some really good things about them. There's some things I don't love about them. The first thing that's great is your voice is louder immediately. You literally just turn up the dial and it's really easy to use. As long as you have batteries, you're good to go. Now, what that can do is it doesn't cause any change in the speech quality. It's going to make it louder, but we're not going to get that clarity improvement, rate, or articulatory kind of a crisper diction. None of that's going to change. We're just going to make it louder. It also doesn't address those physiological changes we've been talking about between the respiratory, the phonatory, and the resonance characteristics of speech. So we're not seeing any changes to those systems to improve things over time. We're just turning volume up. And then some people have said that they can be a bit large and intrusive. You really are literally putting a speaker on the table with a headset on. So I've got an example here of a speech pathologist demonstrating.
So I'm going to start whispering now. Six, 7, 8, 9, 10. Maybe we'll say some marriages in a minute.
All right, so you could hear that certainly his voice did get louder as he turned the volume up. I'm going to address this, and I just wrote it down. I don't like whispers, and I'll tell you why when we get to the swallowing side of things. So if you came in to see me and you were in a full whisper, we could maybe do this as a stopgap, but I don't want you to keep whispering long term. He did mention saving a few marriages. He had made a joke earlier in the video about the difficulty of communicating as spouses and how that can frequently be how we get our initial referrals. It's really when things come to a head communication-wise in your marriage, and that's very typical and very normal, and something that we should be addressing, making sure that you and your partner do have a strategy and the tools you need to be able to communicate effectively. All right, our next technology approach is called alternative and augmentative communication. Now, when I went to grad school many moons ago, this was very cool, high-tech things with touch screens and speakers, and nobody had heard of that before. Now we all have one in our pocket. So much more familiar technology than it used to be. This again, very easy, it's an immediate volume increase. It can be easy to use. It depends on the system that's set up for you as far as how intuitive it is. And that's something that you and your speech pathologist would be working on as far as identifying the software and the platform for it that's easiest for you to access as quickly as possible. You're completely eliminating the use of your voice for this one. So you're not going to experience any changes to your voice volume or quality. We've basically just short-circuited your voice, and you're going to use a computer. The same side of that coin, you're not going to experience any physiological changes or improvement. You're not talking anymore. And remember, use it, lose it. We kind of are beyond that at this point. And then also some people consider it large and intrusive. Typically, people that feel that they still have an effective voice don't have great adoption for a technology option. It's not as fast, it's not as easy as just opening your voice to speak. So I've got a video also of a gentleman using an AAC device.
There's off-the-shelf synthetic speech that approximates someone's voice.
Hello, this is my voice.
And then there's message banking. This is the main menu of all of your phrases.
Hello, my name is, what's happening? Hey, Kat.
So in this example, it's a gentleman with ALS. ALS has a very different trajectory than Parkinson's disease, and typically we know when we see someone with ALS that we need to start banking their voice. That's actually a technology we have now where we can use your own voice for pre-recorded messaging, we need to do that early because they will end up needing an AAC device. That is not what happens typically in Parkinson's disease, and we can typically preserve your own voice using your voice box for a very long period of time into the very late stages. All right, so the last of the technology approaches we'll talk about today is the SpeechVive. Again, this is the company I work for, but I am also a speech pathologist. So what this does is it is worn in the ear. Actually, I have one on my desk. I was using it earlier. So it just goes in the ear. Oh, and it's turned on even. And it's going to leverage something called the Lambert effect. And what that is our natural response to increase our speech volume when we're somewhere that's louder. So when we go into a crowded restaurant or a concert and there's a lot of ambient sound around us, we automatically, without thinking about it, increase our volume, we slow our rate, and we enunciate more clearly to be heard and understood. This isn't even unique to humans. They've studied it in other communicative creatures like whales, monkeys, and songbirds. So it's fully automatic. We don't have to train it. We don't have to do any type of intensive therapy to get you to remember to be loud. We're just going to trick your brain. So what happens is you put the earbud in your ear. When you talk, sound plays. It sounds like background sound. It's tuned just to your voice to give you the bump to make you speak louder, loud enough to be heard for those important conversations. When you're not talking, the sound turns off. So we're getting the same outcomes as LSVT and Speak Out, but we're getting it as soon as you put the SpeechVive in your ear, not after 16 or 12 to 16 hours of therapy. Also, your home practice goes away because when you wear the SpeechVive, every time you talk, you're triggered into that loud voice without thinking about it, and that's putting that load through the system to work on breath support, phonation, and the articulatory clarity. So it's all happening just in the normal course of your daily conversations. We've also seen a more efficient use of the speech mechanism over the long term. So we hear louder speech with longer phrases. So that means better breath support is happening. We see the rigidity release in the rib cage. We see the vocal folds valving more normally, and overall more natural and efficient patterning for speech. So I'll show you a video of this as well.
And,
What bothers you about your speech or your voice?
and then kind of can't, no volume. And it's because of the moment, it's not, my speaking is not clear. It's getting worse. When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above.
Okay, Leo, so I am recording you again, this time with the SpeechVive. Can you just turn your head all the way that way for a moment, just so I can capture that in your ear? Yep, okay. And I'm going to have you just read that top paragraph of the rainbow passage, and you can begin.
When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of light, white light, into many beautiful colors. These take the shape of a long, round arc.
All right, so the only difference there was he put the device in his ear, and we saw that louder and a little crisper speech immediately. So I know we're going to save questions to the end. If anybody has any that they want to ask specifically on speech, feel free to type them in to Elena, and I know she can interrupt me as well. But we'll go ahead and transition over to swallowing. And swallowing seems to be kind of the hot topic. I had some, pre-submitted questions, and everything seemed to have to do with swallowing. So I will try to be as thorough as I can. I have a feeling you're not going to like all my answers. I will apologize in advance. All right, so just like 90% of people who have issues with speech, 90% of people with Parkinson's have issues with swallowing over some point in their disease process. This has everything to do with it's the exact same mechanism. I'll show you how we use it differently, but that's actually why the speech pathologist is involved. We're kind of the experts in this area. So what are the complications that can arise from problems with swallowing, which is called dysphagia? The big one that we get worried about is aspiration pneumonia. This is a pneumonia that's caused by food or liquid going into the lungs when you swallow instead of down the esophagus into your stomach. When we get food and liquid in our lungs, we don't like it, and it can get infected and cause pneumonia. This is unfortunately a pneumonia that is not preventable with the vaccine. This is the type of pneumonia where, sometimes you might hear of a friend or loved one who fell and broke their hip, went to the hospital, had surgery, they were laying on their back, they got weak, and they got pneumonia. It's that pneumonia. It's a bacterial pneumonia. Other complications, malnutrition and dehydration. If we're not getting the food and liquid to your stomach, it's not doing us a lick of good. So we've got to get that figured out. Again, why are we talking about this? Self-efficacy. By the way, that's a topic at the E3 conference coming up. Register now. So is speech. So you can tell who may have been involved in helping with that. So with self-efficacy, you're going to know you got a swallowing problem quicker than anybody else. There's probably some foods you've been avoiding. You're noticing it takes longer to eat, or you're having to take smaller bites, or it's just not as fun anymore because it's so effortful. No one's going to know that other than you. So you got to speak up. You got to tell us. You got to let us know this is a priority. Also, end-of-life planning. I know this is not always what we want to be thinking about, but you need to be informed and understand what the disease process may look like. 40% of people with Parkinson's disease will die from some type of dysphagia, aspiration-related event, be that recurrent pneumonia or a choking episode or something related to dehydration and malnutrition. So as far as end-of-life planning, this is something to start talking about as soon as possible and really have discussions with your doctors. If there's a caseworker or a social worker involved, really asking those questions, and the speech pathologist as well, because you've got options as far as tube feeding. Is that something you want to talk about? That doesn't prevent all your risks of aspiration. And so it's important to understand what that is and what that might look like, and really what your wishes are so that what you want your family can do for you. All right, another face chopped in half. So this should look a little familiar, but we're going to talk about where the food goes this time. Right here, these are your lips, and this is your nose. Down here, this is your airway, so your trachea. You've got a lovely flap right here called the esophagus, or sorry, not the esophagus. That's the epiglottis. And then in the back is your esophagus. So when you take a bite, the food starts at the lips, moves into the oral cavity, your mouth. You're going to chew, 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 mix it with saliva, and it turns into what's called a bolus. A bolus is just a cohesive mass of food or liquid. Then your tongue is going to push to the back of the throat. There's all types of little sensory alarm bells and whistles going off in your brain during this process, letting your musculature and the entire sensory process know you're gonna swallow. This is a timing thing. So that's moving to the back of the throat. You're preparing to swallow, which means your larynx, your voice box, is gonna move up and forward. That epiglottis at the same time is going to close over the trachea to close off that windpipe. So food and liquid cannot go in there. It's going to cause a nice slip and slide so that the food or liquid goes down the esophagus. At the same time, your esophagus is typically closed. It's a sphincter, and it opens as you swallow to allow the food to pass. Closes again so you don't get acid reflux and everything goes down to the stomach. There's more that happens below that upper esophageal sphincter, but that's another day. All right, let's watch a video.
Swallowing occurs in 2 stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis.
All right, that's another day. So as you can see, it's a timing thing. Again, that motor control, the sensory side, those should all sound familiar from what we're looking at and things that might have changed with a Parkinson's diagnosis. In fact, there was a study done where they really tried to parse out the sensory changes in Parkinson's disease, and they actually had people with Parkinson's inhale kind of a watered down pepper spray that would typically make you cough and be rather uncomfortable. About 80% of people with Parkinson's did not have a cough in response to that inhalation, which means also if you swallow wrong and food ends up on your vocal cords, you are less likely to feel that and then cough it out. And that's what those were actually made for. Speaking's kind of a nice tertiary bonus to having vocal cords, but they were actually made to just be airway protectors. So those are all things we're looking at. That's also, okay, so when I talked about whisper and why I would never leave you with a whisper, vocal folds, that is your last line of defense. If you swallow and food and liquid ends up in your trachea, those vocal folds slam shut and they make you cough and choke. And that's them popping whatever that foreign material out of your airway. So that is something that we want happening. So if you have a little puny cough, a kind of cough, you better tell somebody you need to see a speech pathologist, and you should give them a call right after this. Because we want to work on that, and there's things we can do, and we're going to help you. And happy accident, your voice will probably get stronger too. So symptoms of dysphagia. We talked a little bit about this. You might notice you have to eat more slowly. Food feels like it's sticking in your throat. There's 2 sets of pockets that kind of flatten out when we swallow. If things aren't working right, things can feel like they're stuck. I know I've had that feeling kind of with a pill before. You might get tired. It just takes so much energy to eat now that you just aren't eating enough. You're not eating as much as you usually do. You're not getting enough calories. With Parkinson's, we know that your metabolic rate goes up. So not only are you maybe getting tired eating and it's not pleasurable and it kind of is uncomfortable, but you need to eat more calories than you did before. So you've got a double-edged sword there. You may have coughing or excessive throat clearing when you're eating and drinking. Difficulty swallowing pills, and I know that was a question. I'll answer it at the end for sure. You may experience some drooling. Unexplained weight loss, we talked about that. You may avoid some foods that are harder to eat. I know for a lot of people that's bread, and that's pretty common. That's that nice sticky bolus that just doesn't want to go down. Again, pneumonia, especially a recurrent pneumonia. If you tell me that you've had pneumonia 3 times in the last year, ding, 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 you get to see me for a swallow evaluation. We're going to talk about it. So, and then there are studies that show that it may be less than 10% of people with Parkinson's that actually experience those symptoms. So that's, that study I was telling you where the sensory side could be disordered, and you may not even realize that it may not feel harder, it may not feel like choking or even having a cough, but I'm still going to want to see you and see what's going on. This is where getting in to see a speech pathologist early is great, because we can probably catch some things and then give you the education and help you see those warning signs as you go forward. Oh, look at that. When should I talk to my doctor? What do you think? As soon as you're diagnosed, as soon as you notice anything, go in and talk to your doctor. Speech pathologists are generally nice human beings, so we love meeting with you. We will answer all your questions. If we don't need to see you, we won't invite you back. If we do need to see you, there's probably a lot of great things we can do together to make your quality of life better over time. So have that conversation early. Again, you're going to experience these symptoms and notice it before anybody else. So don't wait for someone else to suggest it. Don't let them say, well, I haven't noticed that. You are in charge of this. What to expect when you go in to a speech pathologist for a swallow evaluation. Just like before, we're going to do a thorough case history. We want to know everything that's been going on in your medical history. Why are you coming in right now? What's changed? What medications are you on? There are actually some medications that can really interrupt and make it difficult to eat and swallow. We want to know all of that. Again, you're going to make some faces at me. We're going to take a look at how the cranial nerves are working and how the musculature moves and is coordinated. You're going to get a little snack. You're going to taste different textures of inconsistencies of foods and liquids. We're going to kind of see how you handle those and talk about what that might mean. You'll most likely be referred for an instrumental exam. That could again be the endoscopy down the nose, and you're going to eat and drink while we're watching. Or it could be going to the radiology suite for something that's called a modified barium swallow study. It's done under fluoroscopy, which is a video x-ray, and you're going to actually eat and drink food that has a coating of barium on it so that we can see it on the x-ray, and we can actually watch how the structures and the musculature work and the timing in real time. So I'll show you that in a minute. Again, you're always going to get a screen for speech and cognition. We work on all three. I want to make sure we're okay. And then we'll discuss the exam results and the available interventions. Just like with the speech side, you're on a team and you're the team leader. I'm your quarterback. I'm going to tell you what works. I'm going to tell you what's a good option and how many other options you have. But you've got to tell me what you're going to do and how we can work together. And then also, this is a great time to really discuss your wishes for eating and swallowing as the disease progresses. A lot of people have very strong ideas and opinions on what they want. And this is a time to start having that conversation and asking the specialist that actually works on that end of life nutrition side. So let me show you a modified barium swallow study. I just think these are cool. So again, I sliced you in half. You're in an x-ray. I'm going to be able to see the food go in your mouth. Chew, 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 swallow. You'll also see how quick it is, so that timing and sensory side are very crucial. There it goes, a big sip. So that went right down into the esophagus. I didn't see anything go into the front of the neck here where the trachea would be. That's what we're looking at. Those evaluations take typically 10 minutes. Way outside would be 20 minutes. And it's done again in the fluoroscopy suite. The speech pathologist is there, and typically a radiologist or radiology technician is there executing the study. How can I manage my swallow problem? This is the part people don't like me for, so I already made my apologies. I'm not going to do it again. There's no one way to do this. It's very individualized. That's why the instrumental evaluation is so important. I need to see specifically what's going on when you swallow. because when you swallow, it's totally different from when you swallow. Everybody's different. Weakness, sensory, coordination, and actually even our physiology. We could have different anatomical changes going on that can impact where things move and how they move. So I've got to see you. I can't tell you to do one thing. You'll hear nurses say, oh, they just need to tuck their chin. I wish I could see hands. Who's been told? That can work, but it can also actually make it way worse and make you aspirate. So you're not going to find a speech pathologist on the face of the earth that will give you a one and done. We want to see you. We're going to talk about it as a team. We're actually going to try techniques when we do those studies so that we can see in the x-ray suite, okay, what happens if you do tuck your chin? Oh, nope, not a good one for you. Now we're going to work on a different strategy. We're going to do something else. We want to look at all of that. That's also going to help us plan the treatment process. I need to know, am I dealing with a sensory change or a muscular change? Am I up against some anatomical abnormalities that I can't work around, that I just need to compensate for? All of that comes into play. Sorry. Now, some examples of what might be used in swallowing therapy. You might be doing some exercises. You're probably going to be doing some exercises. We're therapists, that's what we do. Some sensory integration techniques. There's some studies that look at using sour or cold and what that might do to kind of wake up the throat and all the sensory components. Compensatory strategies. This is like that chin tuck that may or may not work. Anything that we ask you to do, we will have looked at when you did that x-ray or endoscopic study to make sure it works. There's some that are as easy as tucking your chin. There's some that are 6 steps long and have you coughing and swallowing and coughing again. So it really is specific to what your needs are. Diet modifications. This can be doing some things like addressing, changing the texture of food by maybe grinding meat or choosing softer foods, avoiding breads. It can even be thickening the liquids if we increase the viscosity and make them pour slower and be a little bit more to hold on to. We might get more sensory input and also slow down the fluids to give your swallow time to respond. Those are all things that we can be looking at as well. And then the last one is expiratory muscle strength training. I have a picture of that here. The reason that's on here, this is a newer device with newer research, so you may not have heard about it if you went to a speech pathologist in the past. This is a device that was really looking at, expiratory muscle strength. So that's that exhaling. Remember I talked about that puny cough? I don't want that because it's not going to help you when you swallow wrong. We all swallow wrong, so it's inevitable. What expiratory muscle strength training does is really try to get that exhaling strength up. So that's actually what you're doing. You're holding, basically you're weightlifting with your exhale. And you do it incrementally. It has some great research behind it. It shows it can work with cough strength. It actually can help your speech volume as well. And there's a study going on at Columbia right now looking at the expiratory muscle strength training and SpeechVive together to really give you a double whammy on speech and swallow. So hopefully COVID's kind of put a wrench in everybody's research studies that require people, because we can't get to people right now. So I don't know when that one will be coming out, but it's had some interesting preliminary results that are along the lines of what we thought would happen. General swallow safety tips. This is what all of us can do and try to give ourselves the best chance. And this is something we should all do, not just if you have Parkinson's disease. Use good seated posture. Get your neck over your shoulders and get nice and upright. That gives you, if you do have to cough, the best chance of getting a good cough. It also puts everything in line for that larynx to move up and out of the way and the epiglottis to close over it. Small bites, small sips. It takes less work to make that cohesive bolus, It's less work to swallow, and it can kind of do some energy preservation. And also, it's not a giant hunk of meat to cover your airway. Slow down. We got to eat slower. Again, energy conservation, giving your swallow time to react. Just a really good habit. Straws. I know a lot of us love straws. I don't, because what they do is they can actually make it more difficult to swallow liquids, because instead of that cup coming up to the mouth and a slow trickle into the mouth, when we suck through a straw, it goes right to the back. So we lose a lot of that sensory input and timing that we might need if we've had some changes to our swallow. So try small cup sips and see if that helps. Keep your chin neutral. I see a lot of this. That's a nice big highway to your lungs when you do that. Keep your chin neutral when you drink. Multiple small meals may be easier if you feel like you're getting tired and you just can't eat as much. Break it up. Do some snacks instead of 3 big meals. So eating throughout the day can help you really accommodate the caloric need that you have. Soft, moist foods may be easier to swallow. So instead of a nice juicy steak, ground beef with some gravy on it might be easier to swallow. I'm not saying don't eat the steak. I'm saying you can experiment and see what's working for you. And then we'll make sure we get you some strategies to eat that steak later on. Or if you're a vegetarian, a lovely juicy portobello. This comes up a lot, so I wanted to address it. What can I do about drooling? So it's pretty common that you may experience some drooling, some saliva loss out of your mouth. It really, a lot of times it might feel like you're just making too much saliva, and what can we do for that? It's actually not more saliva, it's less swallowing. Remember that sensory side that's changing? You're not transmitting the message to the brain that you need to swallow your saliva as frequently as you do. So then it's pooling up and it's coming out the sides of your mouth. So again, big things, keep your head level. You know, we kind of start to get into this posture and we've got a nice funnel out the front of our mouth. Neutral head, we're going to be more prone to swallow down instead of fall out. Reduce your sugar intake. I'm sorry, it increases saliva production. So you can experiment with that and see if that works for you, if eating less sugar causes some changes. Sucking on a hard candy or chewing gum, certainly there are choking risks there, so you need to assess what your ability is. But those trigger you to swallow more frequently. So you can try that and see if it helps. I have also had people use a sweatband on their wrist, and before they start talking, often you may experience drooling right before you start talking because you've had your mouth closed. Then you're opening it and you have a loss of saliva. So before you start talking, you can just do a quick little discreet wipe. I try to train a swallow, but that's hard to do sometimes. Do a quick swallow and then start talking. And then you can talk to your doctor about medication management. There's some patches and some pills that may help. They do have side effects. One of the pills I've experienced a few patients who have had an increase in confusion and delirium with it. So you need to ask about any type of complication or side effect before you would start any type of medication. All right, my last screen. What can I do next? So discuss any speech and swallowing concerns you have with your doctor. It's, like I said, it's insidious. 90% of people with Parkinson's will experience changes. So your doctor understands this and knows this. And this can even be, you don't have to wait for your next visit. If you're sitting here ticking off symptoms on the list as we go through these, you can call the doctor and ask for a referral over the phone to speech therapy. And most doctors will go ahead and do that. So you don't have to wait for that 6-month appointment. Request that referral to a speech language pathologist. Identify your personal goals for your communication and nutrition. You're the head of that team. Make sure your needs and your wants are understood by everybody on it. Then you're going to execute the plan. So if that's doing LSVT and 16 hours of therapy and daily homework, you got to do it. That's what the study that the protocol is based on, a study to get the outcomes. That's what you got to do. With eating and drinking, if it means that you're doing a compensation to keep your airway clear when you eat and drink, you got to do it. And again, use it or lose it. The sooner you get in, the more tools we have that we can help you with this and keep your quality of life as high as possible for as long as possible. So that's speech and swallowing in a nutshell. I know I've got some questions. Feel free, if you guys have any more questions, type them in, or if you want to raise your hand. I'm happy to answer anything that I can, and if I can't, I will get resources for you. So one of the first questions was, what's the best way to swallow pills with water? That is something a lot of people have a hard time with, especially as we get older and our pill box gets bigger. And sometimes we've got those nice giant iron pills or multivitamins that just look like horse tranquilizers. So sometimes it's not using water or another liquid. A note on that, you know, I'm sure you all know grapefruit juice is kind of a no-no with pills, so don't do that. And then even with the levodopas, you got to be careful with your protein intake at the time of pills and medication administration. So if you have questions on that, ask your doctor. Sometimes taking your pills with a more viscous substance like applesauce or yogurt can be helpful. There is a product, and I didn't have a chance right before this to Google it. It just came out, and it claims to make it easier to swallow pills. I've talked to a lot of clinicians I work with. We haven't tried it yet, so you can Google pill swallowing easier and it will probably come up. I don't know anything about it at all other than I've seen an ad for it. But people are trying. This isn't just you. Pills are hard. You can also talk to your doctor about if you have some pills that can be split or crushed. Anything that's an extended release cannot be. So be careful with those carbidopa, levodopa pills. You got to be real careful with those. But ask your doctor. You can also, sometimes liquid forms are available. So let them know you're having trouble with it. They may just be able to order it in a suspension for you. All right. The next question, do speech pathologists work with clients to address the breath swallow cycle? So that was a great question. I've never had that one before and I like it. Thank you. In that video, it did talk about there is an apneic or a breath hold episode when we swallow. Remember, we're closing the vocal folds and we're putting a flap over the top of the windpipe. So there is an automatic timing where you stop breathing. This is why I like seeing the instrumental side. Make sure all of that's happening, everything's working correctly. If it's not, we absolutely do address that. And there's some, they're called maneuvers. One of those that I said was, 7 stages long with a cough and a breath hold and a swallow and a cough, and then turn yourself around and shake it all about. That one is addressing that breath swallow coordination side of things. So yes, we do actually look at that. Foods to avoid, I think we talked a little bit about that. Bread's a biggie, and that's a tough one because I like bread, and I'm sure most of you do too. And you can try different kinds of bread. You can do some experimenting. The crusty French breads are really tough to eat. I choke on those. But maybe a crummy or multigrain might be easier. A soft white's real hard to chew sometimes. It can really get gummy. So it could be experimenting with that. Same thing, just the tougher things to chew that are harder to break down into those small boluses. So it really is looking at what's best for you. You can actually, even in these studies, which is so fun, if you came in and you told me, you know, I'm really having a hard time with steak, but I'm a meat and potatoes kind of person, I'm gonna eat my steak, I'm gonna say, great, bring some in, and I'm gonna put barium on it. It's gonna be the worst steak you've ever had, but I'm gonna see how you do with it. And we're gonna see what we can do to make that easier. So think about the specific foods and textures that you want to be able to eat and talk about that. Okay, there was another one. How do I help my dad understand the importance of doing voice exercises? Boy, oh boy, if I knew the answer to that, I would share it, I would ring it from the mountaintops. So there's a couple things going on that make it really hard. The first one is, I've said it a lot, sensory. So there was actually a study done where they were trying to really look at this sensory piece of speech in Parkinson's and what was going on. And they had people with Parkinson's rate their volume compared to other speakers' volumes. And guess what they rated their volume as? Towards the top. There's a sensory disconnect. They don't feel like they're speaking at a low volume. And when they speak at a normal volume, it feels like they're shouting. So it's really hard. Think about if I told you I want you to shout every time you talk for the rest of your life. Do it now. Do it forever. And then I need you to practice that. That's hard to do. It feels weird. That's where the protocol comes in to really try to normalize that feeling. It's a lot of back and forth of that's loud enough or that's not. I need you to go more. That's what it should feel like every time you speak. That's normal, and getting that to feel normal. But again, use it or lose it. If you do great and you're a star pupil in therapy and then you never touch it again, you wasted 16 hours of your life, because you gotta keep it up. If you don't keep it up, it's not gonna feel normal anymore, and physiologically, you're not going to get that louder voice over time. You're fighting against a disease that's trying to decline. You have to fight to keep your ground every day. So I hope if the child that asked that, if they're on with their dad, that was impressed upon you. Use it or lose it. That's one thing I do actually like about the SpeechVive is it takes that home practice away. And instead of saying, Dad, use that loud voice, you just say, Dad, put the SpeechVive in your ear, and then it's there. So that can be helpful. I've got other patients that really want to do a protocol. They want to check the box every day, and they want to do that. Absolutely, we can do that too. So lots of different options available. I think that's the end of the questions that I had from earlier. Elena, are there any other things to address?
Yeah, there are. We did have a couple come in during the presentation. So the first comes from Karen, and she asks, does Parkinson's affect the singing voice?
Yeah, that's a great question. So I alluded to that a little bit with Linda Ronstadt. She noticed, you know, obviously my voice doesn't sound quite like Linda's when I sing, so it probably wouldn't be the first symptom I would experience. But for someone that's a professional voice user, it's very understandable that she would experience some changes. So she actually said what she experienced was a decrease in pitch range and a decrease in that breath support for her phrasing, singing. That has everything again to do with the same musculature as what typical speech is. So she had some restriction in her larynx, allowing her to move her vocal folds to stretch them into this pitch range, and then again the breath support. So absolutely, it can affect your singing voice.
Awesome. Okay, and it actually looks like Diane raised her hand and she had a question about mucus. Diane, I'm going to go ahead and try to unmute you, and you can ask your question directly. You may have to unmute on your end as well. There
I'm
you go.
sorry, I didn't mean to have to talk. I just wanted to know about extra mucus. Is that also something that can interfere with talking and eating, all that?
Yeah,
Okay, thank you.
Yeah, you know, this was our hot topic the last time we did this, because it was right at the beginning of allergy season. Anytime you have thick crud in your throat, it's resting on those vocal folds, it's coating your throat. It can change the sensory side of it. Absolutely. That's something that you can talk to your doctor about, and there may be some medical interventions there for you to try. Staying hydrated can help thin it. Okay. So those would be the strategies to use.
Okay, thank you.
Okay, we got another one coming in from Jane Fraser. She says, my singing voice is awful now, and it sounds like I have vibrato. My chin also tremors, which I think might contribute to the vibrato thing. So absolutely, I know, you know, we kind of addressed the speaking side, the vibrato side. They've actually done some studies looking at tremor in the vocal folds specifically. So it could be, full disclosure, there are some speech pathologists that are former opera singers and professional singers. They would do a much better job addressing this, and specifically vibrato, than me. I believe vibrato can come from the jaw, but I also know that they have looked at using examination and of the vocal folds, looking at tremor in voice quality as perhaps an early indicator of Parkinson's before other symptoms. So you can actually have tremor within your voice box, which would cause vibrato as well. I'd say just use it. I can't do vibrato. I can't help you with your singing voice, but I can certainly find someone that can, and voice and speech exercises can work on that, because a lot of what we do is pitch range. Okay, we'll go ahead and wait for any other questions to come in, but while I kind of wait, I'll just reiterate that we follow-up email. There we go. Follow-up email will be sent out tomorrow around this time, and it will have a recording attached. And please feel free to share that. It will also be on our YouTube channel, PA Rockies, Parkinson Association of the Rockies, if you'd like to go check that out. Yeah, I don't see any of the questions coming in, so we'll go ahead and wrap it up there. Make sure you download any of the handouts that we have. E3 should be great. There'll be a session actually with the developer of SpeechVive, Jessica Huber, who we're really excited to have. So feel free to sign up. That can all be found on our website. And thank you again so much, Ashleigh.
Thank you. Have a great afternoon.
Yeah, you as well.
Bye-bye.
Bye.